Hello, I'm Ibrahim Imam, and welcome to this episode of the Neurology Lounge podcast, where we will continue our discussion on Alzheimer's disease. The last episode on this subject was titled Entanglement, What Aloy Saw. There we looked mainly at the pathology of the disease. In this episode, I will be speaking to Tia Powell to discuss her perspective of Alzheimer's disease as documented in her book titled Dementia Reimagined, Building a Life of Joy and Dignity from Beginning to End. This was published by Penguin Random House. Tia Powell is professor of epidemiology and psychiatry at Albert Einstein College of Medicine and Montefiore Medical Center. For 15 years, she was director of the Montefiore Einstein Center for Bioethics, and her bioethics work focuses on public policy, aging, dementia, end-of-life care, and public health disasters. She served as executive director of the New York State Task Force on Life and the Law, which was New York State's Bioethics Commission. She founded and directed Einstein's MS program in bioethics. She has worked with the National Academies of Science, Engineering, and Medicine on many projects, and she currently chairs their Committee for Research Priorities for Preventing and Treating Alzheimer's Disease and Related Dementias. She has also worked with the CDC, New York State and City, and various professional organizations on issues related to public health, ethics, and disasters. She has also served as a special advisor to AHRQ on ethics, dementia, and multiple chronic conditions. She's on the American Psychiatric Association Ethics Committee and is a fellow of the New York Academy of Medicine and the Hastings Center. Dr. Powell received a BA from Harvard College and an MD from Yale Medical School. She's collaboratively developing a film project on living well at the end of life, which is probably something I'll pick you up later on. Tia Powell, welcome to the Neurology Lounge, and I'm very grateful that you kindly accepted my invitation.
I'm delighted to be here. Thank you for the invitation.
My usual first question is why have you written the book? What was the inspiration for putting pen to paper?
Probably like many authors before me, I think frustration was a primary motivation. I'm one of 6 children, and we are very lucky. Everyone is alive and well and educated. And when our mother developed dementia some years ago, she's been gone now for nearly a decade, we were really at sea in terms of figuring out how shall we understand what would benefit her now, how shall we understand how that will change in the future, and where can we get those things? First of all, can we all agree on what that would be? Can she still inform us? And how can we find the things? And I thought, this is such a common diagnosis, and this is happening all across the country, all across the world. How can there not be better guidance for how to try and do the right thing by someone you love who develops dementia? So I didn't write a guidebook. It's actually, as I've been reminded very sharply by many people over the years, it doesn't tell you exactly what to do. The intention was rather to help people think differently about dementia, to be not so frightened of it that they were immobilized, either on behalf of themselves or for somebody else. So I think that was really my motivation in trying to write the book.
Okay. Even though it wasn't intended to be a guide, there are quite a few recommendations which we'll talk about later on, which do sound like good guides. How did you go about writing it? Did you take time off, or you kind of had to squeeze in 5 minutes? It's there.
Yeah. Some of all of those things. I was lucky to be able to get a 6-month sabbatical, which was not enough for me as a first-time writer, a first-time book author, to write the whole book, but it was enough to sort of sketch out the arc of the book and to get the first few chapters written so I could do a book proposal and get that sort of settled and everything. And then I was able, nights and weekends, and as you say, squeezing in 5 minutes here and there, to be able to go back to it, because I had this sort of framework in place. And then I can say, right, chapter 4, I had sketched out the reading I needed to do for that. So I'll plow through and take notes on the articles, and then I'll be able to put that together. So it is very challenging when you have a full-time job to figure out how on earth am I also supposed to do this and eat meals and have a family and do the rest of the things in a regular life? But it was somehow important to me to write this book and to write a book. I think I always meant to be an author of some kind. So I'm actually a little bit surprised that I was able to get it done, but I was.
Well, it's right at the top of my favorite books. Right from the beginning, you stated the premise of your book, which was on the background of dementia lasting for years. And most of the time, people with dementia retain the skills, memories, and passions that allow joy and inclusion. In other words, they're not isolated from the bigger world. And you said, but that's only if we, but let them carry on in that way. By saying we there, who are you talking about, society or medical, or the medical fraternity? Or who is
I would say all of us, kind of, not even a royal we, just sort of everyone, because I think both medicine and people generally see dementia as a death sentence, and it is indeed a fatal illness, but they see it as death in life. I had a very nice book agent, and I struggled with the title for my book, as is common. And he, having read the book, suggested, or read at least part of it that existed then, suggested, I know, how about dementia chained to a dying animal? And I thought, okay, that's very helpful. That's exactly the opposite of what I'm looking for. That is, but it's very helpful. That I think that's what people imagine, that it's the person is a dying animal and that you as a caregiver are in some way chained to this horrible monster. So none of that. Please stop that. Like that's really one of the you've quite captured the central thesis of the book. And among the adjacent concepts are dementia is a bad illness. Absolutely. One suffers and it goes on for a long time. But part of the badness of it is something that we put on it. We make it much worse than it needs to be for the person with dementia and their family by being frightened, by running away, by saying, that's just so horrible. I won't plan for it for myself. We won't plan for it in our community. We just think that that's death in life. It's the worst thing ever. And there are a remarkable number of people who say the day I would be given this diagnosis is the day I would kill myself. And I just, I mean, I'm not judging that. I'm just saying, is that really the only alternative or the best one? Couldn't we come up with a few options? Maybe not everybody wants to do that, but it shouldn't be so obviously terrible that people feel that's the only sensible thing to do. And indeed, if you spend time with people with dementia, you will find many, I mean, particularly in the earlier phases, who seem to be having a lovely time, who, when presented with a birthday cake with candles, appreciate that it's their birthday. They might not have remembered that, but it is possible to feel that pure childish sensation of joy, even when you have dementia. And in fact, you've seen an infant express that pure joy. They also can't speak and wear diapers. So there's nothing about being your smartest self that holds the lock to joy. You can have joy, and we should spend more of our effort thinking about how we could maintain and bring joy to people in a wide range of circumstances, including with dementia.
And yes, you did go on to say a lot of the lousiness of dementia can be diminished and compressed.
Right.
And the example you just gave now was people in the early stages of dementia. How much does that apply to the later stages, which is what people kind of have in their mind of somebody with dementia, is people towards that late stage? How much can the lousiness of it be kind of reduced? Even does it apply even to that stage?
I think so. I think we've done, medicine in this case, have done a relatively poor job of thinking about what palliative care would look like at end stage dementia. Unfortunately, it seems pretty clear that there are people who can no longer talk and have lost many cognitive functions who can still feel pain. What a terrible illness. that it takes away so much of what you value cognitively and leaves you with that, the ability to feel pain. So could we do a better job of finding medications or hand massage, other kinds of interventions that can in fact address pain? Because no one should have pain. There's just, it's one thing if you're walking about the universe and you need to make sure you're staying safe, but for someone who's likely to be bedbound and cannot protect themselves at all, I see no benefit to pain. So can we do a better job with thinking about that? The other issue, and this may be more true in the States than in the UK, medicine has made great success in extending life and treating various illnesses. And sometimes we use that wisdom prudently. And sometimes I think we use it foolishly. We need not extend a life that is painful to the person who has it, in my view. I'm not forcing that view on anyone else, but there are people in America who have filled out living wills saying, please don't keep me alive on machines. Please don't give me a feeding tube. Please don't put me on a ventilator. And this is still something, even when they've taken the trouble to express and record their values, that they have to fight for, or their family has to fight for. So I would say that's a misuse of medicine. Death is inevitable. I'm very sorry to announce this to your listeners, but nonetheless, we know it to be true. It's bad news. But when death is coming sooner rather than later, we could focus more on a good death rather than extending a life that that person themselves has indicated is no longer, extending it, merely extending it is not a benefit to them. So I would say we can do it two things. We can make that life not be painful, and we can make sure that we don't extend it against the wishes of that person. And that would help a lot.
That brings to mind, I think there was a survey about physicians, and most of them would opt, if they were terminal or in a terminal disease, not to be given these life-prolonging interventions. They prefer to do what they don't give their patients, I presume. And this failure of medicine came into this other concept you put across, which is the dichotomy between care and cure. And medicine has put in so much, you said, big bucks and glory into cure, but very little into care. Why has that happened? Why have we emphasized the search for a cure, kind of put the care aspect in the background?
Well, I think it's, like all interesting questions, it's quite multifactorial, I would say. Science has bloomed so beautifully in the last 100 years and more. And we can now understand so many things and have an impact on so many things that would have been inconceivable to physicians 150 years or so ago. So it is great that we push toward the cure. It is great that we've made enormous strides in heart disease and lung disease and all kinds of things, and cancer. Cancer is a completely different disease to treat today than when I was in medical school. Now you look at the genetic profile, you can figure out exactly which drug is likely to work for this person, which will not. You can focus on doing the most benefit with the least liability, and treatments are fantastic. So that's great. We should certainly do that. But medicine was always about both. It was always about providing comfort. And we've tend to let that slip away as we become, reasonably so impressed by our ability to use technology and go towards cure, but we forgot our ancient duty, that comfort was always, always part of our obligation. And it remains true for us that even though we can do a lot of things we didn't used to be able to do, there are many things, and very specifically dementia, that we don't cure today. And I in no way denigrate those who are working to find cures, to find ways to ameliorate dementia. That's a beautiful task, and many very smart people are working toward that goal. Meanwhile, pretty much everyone who has dementia today, not really likely to benefit from the cure. Most of the research is only aimed at people who either have very early stage dementia or don't yet have any symptoms at all. So we're not actually, for the most part, even working on treatments and cures for people with quite advanced dementia. So we should remember, for that pretty large group, we still have an obligation to comfort, to provide care, and to figure out how we can do that better. It's always expensive. It involves a lot of manpower, person power, and that's tricky. Lots of economies are shaky, and COVID was terrible in every way, including in its financial impact on healthcare systems globally. And so I appreciate it's very difficult to figure out how to provide good care. And it's not, I mean, we can be smarter and use AI and robots as much as we want. Still, at the end of the day, a lot of care for people who are very physically debilitated must be done by other people. So we're not going to scoot away from that obligation anytime soon, I would say.
And one of the reasons you gave for this emphasis on care, I'll quote you there: a masculine medicine striving to provide heroic cure, overshadowing its feminine side that offers care. Now, I know the demographics in medicine is shifting a lot towards women achieving or getting into, well, taking over medicine, let me say, I think more than 50%. Do you think that would help to shift the emphasis?
Well, I wish it would, but I don't know that it will. Certainly growing up as a professional woman in medicine, when there were relatively few of us, I had very few professors and, senior women. There is much to be said not in favor of the overwhelmingly hierarchical, heavily masculine atmosphere that was present when I was there. However, I have to confess that the worst supervisor, the worst boss I ever had was a woman. Okay. So it is not the case that if women ran, as far as I can tell, there's no evidence to support the notion that if women ran the world, it would be definitely a gentler, kinder place. I wish we had some group about, whom you could say that, but I don't think it's women. I think that power corrupts. I think that people who are busy, who are pressed, who have enormous pressures on them to deliver, to provide, to do this, that, and the other, have trouble holding on to sometimes the core motivation that they had. I remember that argument, this is years and years ago, with, I think, a medical student. I was a young physician, and they were saying, like, oh, all these young physicians in training, they're so awful. They're so completely lacking in compassion. And I said, if Jesus Christ were an intern and worked for 100 hours a week, many weeks in a row, I think we might have seen more of his famous temper, in his day-to-day work. So, and we are not Jesus Christ. So, I think a little humility, a little compassion for those who are struggling to do that. So I do think, I'm not sure that having more women will make a difference. I think, I don't know if this is women causing this. I think that there is some shift in focus towards work-life balance, even in medicine. Pretty much every other field in the world is there before us. But I think we are also beginning to think, physician, heal thyself. If you feel that your life doesn't permit you to spend time with your newborn child or your partner, or to forgive yourself for an error, acknowledging your responsibility, but also forgiving yourself. If you feel you can't do that, how will you provide compassion to others? How will you do that? I think we're getting there, but I'm not sure if it's only because more women are around. We'll see.
That's a thought. I never saw it that way. And we'll talk about the prospects of cure later on, but suffice to say at this point, the prospects are vanishingly very low. Are you pushing in your kind of advocacy for a kind of 50-50 between care and cure, or a more radical shift towards care, much more than what we're doing now?
I think it's always both. I feel that the push in dementia towards cure is very powerful. And I'm not sure that much more. There are many people who are advocating for that. There are many dollars from National Institutes of Health in the States, and this is a huge research challenge that is recognized and that is being worked on by many, many people, as it should be. I do think there's still a need for advocacy that relates to care. So it's not, I wouldn't presume to know exactly what the balance should be, but I do think it is easier to get attention for saying, we're going to cure this and we have fantastic new, scientific methods. It's often falsely sold, I will say. I think there are a lot of people who say, if we can cure this, we'll save money.
Yeah.
And I just have to say, I don't think the data are there. I mean, for the first drug that was approved by the FDA in the US, the cost per person would have been almost $100,000. It was an injectable. Their initial price was very high. Not an injectable, it had to be infused. You had to sit in a chair and have a nurse take care of you to get it administered. And aducanumab, for what I would describe as extremely slim benefit, would have been about $100,000. Actually, with that amount of money, even in the States, so expensive, you could provide fabulous care for every person with dementia and know that you'd actually improve their quality of life, which is not something that I would have said about aducanumab. So the notion that a drug, a pill, a thing will cure it and will be great strikes me as, shall we say, not evidence-based. And first of all, the vast majority of people who have dementia are also older. So they will have other illnesses and other requirements. They may not see well. Their mobility may be impaired. They may have all kinds of things that not unreasonably make them more likely to need some sort of assistance to get through. So I don't know that you can somehow make everyone into a Superman or woman and then nobody needs care anymore. It's like, what image of humanity? Like, what are you smoking? Where is that? How is that going to happen? It's just like, anyway.
A pie in the sky is a term to use.
Yeah, exactly.
Well, clearly your journey centered around your own experience of your mom's dementia. And you talked about how that was quite frustrating or unsatisfactory. What did you observe during her care or during her journey that made you so dissatisfied with the system as it is now?
I remember, this is such a small thing, but it was, for me, a powerful illustration. My mother had always, and my mother was such a hardworking person. She had 6 children. She was an incredibly involved mother. I mean, and we were just, everybody with hockey and soccer and piano lessons and this, that, and the other. It was like she was running a kind of B&B, constantly for all of us, with food and meals and equipment and all kinds of stuff. So she used to love to take soaky baths, as she would say. Like a hot bath for her was the most incredible luxury, and probably one that she didn't get to do that often. It was probably, really tough for her to. So when she went off to a skilled nursing facility, they made a great show of showing that we have this, a bathtub here. We have a room where a person could do that. It's fabulous. That would be wonderful. They never let her do that because they were too busy. The culture of most skilled nursing facilities, and I don't bash them, they were as hard-headed as any group in the world during COVID. They were and are terribly short-staffed, and the culture must focus on safety first, which is, we don't object to safety, but safety is always balanced against freedom. So that when you have an infant, sometimes we swaddle them up and we sort of keep them cocooned like that. If you're not a newborn infant, that's not necessarily a particularly pleasant way to spend your time. So between the shortness of staff and the fear that she would slip or fall or sink beneath the waves of the tub, she never got to do that. And I just sort of thought, no one was intending to be mean. This is hardly an intended torture for somebody, but it was a small thing that actually was a way for her to have pleasure. And she couldn't have that small thing. So I think that's, in a microcosm, a picture of what it is to have dementia. You can't really advocate for yourself. You can't make a powerful argument and say, well, this is the reason why you need to do that, and I'll wait till the time that you just are kind of ground down to an easily transportable sort of widget. There's not that much room for you to say, what would make me happy if you could do this small kindness? That would be wonderful. But they can't really say that anymore. And that's a shame. We should be at greater pains. And some facilities, I think, are really working on that, are really trying to figure out, what would that look like? How could we do some work to find out from people what makes you happy? What are sources of joy that you might still be able to have here? There won't be all of them. If you were a great skier, maybe that's something you can do when you're 92 and have dementia, although probably there are some people that do that. But what would be some small thing that would make this moment pleasant to you? Can't we do that?
Yeah, you did say it's kind of everybody trying to do their best and the system not allowing it. But did you also witness lack of compassion in her interaction with medical staff or any healthcare?
Sometimes, I mean, not so commonly. And I think we were very lucky because there were so many of us. We were able to spend time. And also my father had died first and had left some money, which he, he left us specifically so that she should be comfortable. So when she first went to skilled nursing, or actually the whole time she was in skilled nursing, we were able during the days to have someone also sort of be her appointed caregiver. So she had a physical person there advocating for her and taking care of her. So I think it's, even so, we can be inadvertently insulting as health professionals, calling somebody by their first name when they're from a different era and they have different notions about that. So a young person saying, okay, cutie, or, okay, Sally, it just, at full strength, my mother would never have tolerated that. She would have said, I'm Mrs. Powell. She was kind of a snob, but, that was important to her to protect her dignity. And people shouldn't have to demand that. They should be called as they wish to be called. They should be treated with respect. And we don't always do that. And again, some people are jaded and burned out, but others are just busy and they've sort of forgotten why they came into the business and what things they might do to make it better for their patients.
And you gave a good historical background, which in the early stages, about how our attitude to care has changed over time. And you talked about the reformers, Samuel Tuke in England and Dorothea Dix in America, who clearly must have seen the wrong attitude to care and they tried to reform the system. But you said their advocacy was rejected, and that haunts us to this day. Why were their efforts rejected? Why didn't society?
Well, at first they succeeded. I mean, Dorothea Dix crushed it. There were hundreds of what were called asylums built in the 19th century in America, and many, many dozens. She had a direct role in getting them funded and built and passed and everything. I was just reading the other day the history of St. Elizabeth's Hospital, which is in Washington, D.C., where I grew up. And so for a variety of reasons, I was sort of looking into it. And Dorothea Dix got the National Congress to fund this in the 1830s, I think, because there was no home for soldiers who had mental illness. It was before the concept of PTSD, but they would have seen soldiers who were sort of unable to take up their lives again for psychological reasons after fighting in the war, and for various other people. So Dorothea Dix first succeeded enormously Part of the problem, again, is this sort of mislabeling. Not really by her, but by others. A lot of times funding came, again, with this notion of, if you let me build this hospital, we will treat mental illness early and we will fix everyone. They will all get better. We'll have incredible, 70, 80% success rates, and they'll all go home and be upright citizens and go about their business and do jobs. And that would be beautiful. It is a beautiful thing. And I could see why that would be an effective sales pitch. Even today, we don't say that. And certainly in the 19th century, with what was available to them, serious mental illness remains serious. And that's what the asylums were built for. They weren't built for dementia, but dementia, we still don't have a cure for. You're not going to take somebody, especially somebody who's 85, who has dementia, but probably also has a host of other things, and say, we can make them perfect. They're going to be out there and they're going to be crossing guards at the school and, working in the grocery store at the cash register. Like, again, what are you thinking? Like, are you turning back the hands of time? Because that's really what it would take. It's not just fixing the dementia. So we age. If you don't die, you age. And there are normal consequences of that. So I think at a certain point, the states in the US and other places said, you fooled me once, I'm not going to fund this again. You told me we'd spend less if I built you this building so you could fix everybody and they'd go out and be upright citizens. And look at that, they're staying there, or they go out and they come back again, which is ordinary in the course of most serious mental illnesses. They have a cyclical function. So if you have schizophrenia, you'll be psychotic, and we hope we'll get better and be able to do things again, but you may fall in again, as is true with depression, manic depression, and all the serious mental illnesses. So we think it's more like recovery and stabilization. That's our more modest goal today. And with better supports, we can do more for people. But I think the big reformers did have a beautiful vision of what they wanted to do, and they did succeed in providing that, but it was falsely sold as curative. If they had said, we do it because it's the right thing to do, and every human deserves to be treated with humanity, then they still probably would have stopped funding it, because it would have been expensive, and they would have said, enough of that. Well, let's find a new passion, a new thing that we'd like to fund. But they did succeed, because I think they were able to help people respond from their better nature. I think both Tuke and Dix didn't really, I don't think they were the false sellers saying that this will fix everybody. I think they really said, we should do it because it's the right thing to do. And I think people responded to that. So I hope that with that appeal, we should be able to get farther today. I don't know if we will succeed or not. We'll have to give it a try, though.
Can see. And what's interesting, at that time, of course, dementia was buried within the bigger pool of mental illness. And I was surprised that it was not until 1897 that a case of dementia was published in the American Journal of Insanity. Why was it hiding in plain sight? Clearly, people have known that these set of people are different from people with schizophrenia or other forms of mental illness.
Well, it's such a good question. And there are classical scholars who basically describe what looks like dementia. So it's not that nobody ever saw this before, like, wait, there's this thing that's happening. I think it was very hard to disaggregate dementia from just being older. And so I think first of all, there were fewer old people in 19th century. I mean, relatively few and relatively privileged people lived to a great old age, but it was common to have a fatal heart attack at 50, to die in childbirth for women, accidental deaths. This is well before the notion of safety at work, so if you're working on the railroad, it's like, that's a harsh, so we had fewer older people, And we just thought, old people, go figure. They get dotty, they can't remember stuff. And there are a few that are super sharp, but whatever. That's just a thing that happens. So there was no, and that was very hard when people began to focus on dementia, to be able to say, it isn't all old people. And it isn't something that we must merely accept. It actually is some older people seem to have this problem. And we ought to try and understand that more and see if we can do something.
And it wasn't until the 1970s, you said, kind of dementia came out of the shadows. And a lot of politics, money, science all coming together. How did that happen? How did so many different aspects of society come together in the 70s? What were the factors that enabled it then?
All kinds of things. I had so much fun researching the book for this reason, because even though as a psychiatrist, a physician, I had no idea. I mean, it was all like little weird things I heard, but I had never had a coherent sense of how things develop. So I thought it was really fun to read about. One, there were new possibilities in science. The brain is very hard to image because it's, for purposes of safekeeping, it's locked inside a hard bone that goes all around it. So an X-ray, the earlier forms of imaging that we had, couldn't tell you anything. All it saw was the helmet, So you began to be able to get CT scans and things like that. You could begin to image the brain. Our microscopes became vastly more powerful. So you had things like the electron microscope, incredible, could see things at the level of the cell, unimaginable to our predecessors. So that, science is really sort of like going from strength to strength and figuring out these things. So that's happening. And the brain is a kind of unexplored frontier in many ways. So this new technology makes an incredible difference in what you can begin to figure out. There's also, post-World War II, and this happens across developed economy nations, but I know the history best in the US, there is this incredible blossoming of science. And the government in the US gets deeply involved in funding it. This is incredible. We want to send a man to the moon. We want to cure cancer. We want to do all sorts of things. So the National Institutes of Health are born, and they're all, it's like a mother dog with many, many puppies, all sort of elbowing each other to get the resources and stuff. So when they finally put together a National Institute of Aging, which is one of the later ones to come along, big things like cancer and heart disease and stuff had already been claimed by separate institutes. So they had to think, what can we do that's aging that hasn't already been claimed as turf by other people? And so some brilliant people, including Zaven Kachaturian, thought dementia, that is a disease of the elderly. Nobody likes that illness. It's very scary. There's very little known about it. So there's plenty of room for more work. Let's focus on that one. So that happens. And then you start to find celebrities and people in their own families. So Rita Hayworth had dementia, and her daughter, the Princess Ida Khan, was a great advocate to sort of draw attention to that. And then when Ronald Reagan very bravely announced that he had Alzheimer's disease, wrote a letter sort of to the world, at that point, you cannot be a reader of newspapers really anywhere in the world without having heard of Alzheimer's disease. That sort of did it for an American president to send this note out to the world. There was, you can't ask for better PR than that if you're an illness. So I think the money's there. People are starting to get interested, like, oh my gosh, this can happen to this person. And I also think that more and more people began to look around in their own family and say, oh, that must be what's happening to my grandmother or my spouse, or that we see it right here. I didn't know that that's what that was. So I think, it became a thing that went from nobody's ever heard of it to everyone has heard of it. Yeah, literally everyone, just all of a sudden. That's the sort of short version. I'm sure I'm doing it injustice, but I'm sure.
No, very good justice. And we just go back in history to the man himself, Aloy Alzheimer. The disease was named after Alzheimer by his mentor, Emil Kraepelin. But at that time, I think Alzheimer had done very little. I mean, it's published, it's a case or two at the time. Did Kraepelin rush to give it a name?
You know, I think that's sort of how they did back then. Kraepelin had his acolytes, his sort of followers, and Alzheimer's was one. And they were all off doing, it was really cutting edge research back then, really looking in their microscopes and trying to draw a connection between pathophysiology and symptoms and figuring out what was going on. So that was fascinating. I mean, that's still where we are today. So in that time and place, it was a really cool thing to name a disease after somebody. So it reflects well on Kraepelin that his protege has this disease named after him. And, we stopped doing that for a variety of reasons. One, it meant so that some very unappealing people got diseases named after them. So that makes us feel bad. And also, it's extremely unhelpful to both patients and learners of medicine. Like, if a heart attack was called, if you had discovered heart attacks and it was called Imam disease, it's like they would all be saying, wait, which one is that one? Is that the one in your heart or in your lungs? It's much better to call a heart attack, something that the person can, just call it for the organ that it's in, call it for what's happening there. It's really unhelpful to call it Smith disease or Imam disease or Powell disease. It's really just like, or name it for the bacteria, name it tuberculosis, name it, So we don't do that anymore for a variety of reasons. Well, we don't want the people who suffer from this illness to be forever linked to somebody who we may not admire so much later on. The Nazi doctors being kind of an example there. We don't like to kind of link poor sufferers to an unflattering association. But so I think it's just kind of how they did things back then. Here's something, this looks cool, this looks new, let's name it after this guy, why not?
I think there's some disease where later it was discovered that actually the disease the person named actually wasn't the disease. It was something else completely. One of the great revelations for me in the book was Solomon Carter Fuller, who I'd never heard of him before. He worked with Alzheimer for about a year. But you painted the picture that he had a better insight of the pathology of Alzheimer's disease and what that implied than Alzheimer did himself. What kind of person was he? And how come we don't know much? We don't know anything
fascinating. Yeah, he was so fascinating to me. He had been born in Liberia. His grandparents, I believe, had been enslaved in the US and went off to Liberia with that movement in the early 1800s, I believe. So Solomon Carter Fuller was born there and then came to the US. He is the poster child of immigrants, of who you want to sort of come to the country and like be ambitious and work incredibly hard and do great things. That was absolutely who he was. So he comes as still a teenager, and he ends up, gets himself an education. He went to what we now call an historic Black university. It was not, it had at that point very little history. So he went to a college that was set aside for Black students, either born in the US or immigrating in. And then he went off and he gets himself to medical school. He might have been able to go to Harvard if he had waited another year. He learned while he was applying to med schools that that they were beginning to think about a scholarship, and they probably would have given like one per year in a very sort of, kind of tight-fisted fashion. But they hadn't quite gotten it together when he was applying. So he went to Boston University, did very well, extremely ambitious, and I would say also extremely dedicated in figuring out what is the best training. So he got a job following medical school in psychiatry in one of these big asylums, and those were a great source of jobs, actually. and also in many ways, probably not the most desirable job. Because I think his opportunities, despite being fantastically diligent and successful in his studies, his options were limited because of his skin, because of his background. So he goes there and gets really into pathology, and he's studying brains, and he's thinking about, he does autopsy after people die, and he's learning about all this stuff, and he connects with a great pathologist in New York City and says, how can I keep learning? How can I study as well? As was true then in the US in the 19th century, the best people go study in Europe, and specifically Germany. So get yourself to Germany. So he applies for basically a postdoc, and he is one of 5 students accepted into Alzheimer's lab, and he goes there for 2 years. I mean, they didn't even mention it, the little things I've read about him. He obviously was doing all of that work in German for those 2 years. So somewhere along the way, he taught himself German. It's like, okay, fine. Just like we won't even mention that. And he's reading, German as a native and doing all his work there and working in the lab. He spends 2 years there. So when he comes back, he is probably among maybe 2 dozen people in the United States who are the best informed about cutting edge research in the brain and around what we've come to think of as dementia. And he reads Alzheimer's paper when it first comes out a few years after he gets back. And he says, that's interesting. Not many as you were observing, it's not that many cases, sir. And also he comes up with this statement that basically, these plaques and tangles, and he was familiar, he'd seen them. He was doing all sorts of slides and cutting into, brain sections and pathology and stuff. He said, I don't think they are neither necessary nor sufficient for dementia. Boom. I mean, it's this is still the argument that we're having 100 years later, and we are better able to see and test things now. We're peeling off. I mean, when I wrote the book, I don't think, or I was unaware of a resolution to an enormous problem in Alzheimer's disease, which was that they used to just have clinical exams at expert centers for dementia, and people would then refer those people with the clinical signs and symptoms of Alzheimer's disease to enroll in studies, and then they would give them drugs that reduced amyloid. And for some of the big like A4 trials and things like that, after they took in all the people, and when the results were really not good, they realized up to 1/3 of the people in the trial had the symptoms of dementia, but did not have elevated amyloid. So you could get, in effect, the disease. It was not necessary to have the amyloid to look just like you had Alzheimer's. And frankly, what do you care what's going on in your brain? You're worried about the symptoms. If you can't find your house, that's what's troubling you, not what's happening in your brain. And the other side of that, we know that about 1/3 of people into their 80s who have, or let's say 1/3 of people who have normal cognition in their 80s have high amyloid. So it is not sufficient. So he's quite right. It is neither necessary nor sufficient to have the clinical syndrome that looks like Alzheimer's disease, and amyloid doesn't explain that. So I'm not saying it's nothing, but Solomon Carter Fuller was an honest man, and apparently those are extremely rare, and a keen observer who sort of said, yeah, looking at the data, I don't think so. And it took us basically about 100 years to come back that. And I think, he was little known. He almost certainly would have been a director. He was made chairman of his department, but was never given the title. He was let to do the work and was never given the formal title at Boston University, which they were appropriately ashamed later on. They named a building for him. But it's a story of a man who had, I think, a successful life, a life that he was proud of, and who was much too little known to the rest of the world. And that was on us. That was our fault, or the fault of those who were living in that time and whatever blinders they had.
Well, I'm glad you highlighted him. It's quite inspiring.
I'd never heard of him either. Actually, I think I'd vaguely heard of that building up in Boston, but I didn't know, what that had to do with or anything. Yeah.
What does that say about the state of neuroscience, or the progress in neuroscience, that it takes that long to get back to what we should have known so long before?
Well, science is always going by fits and starts. That's the scientific method. We have a good idea. We think this will explain something. We set up an experiment. We see if we can get it funded and implemented. And we look at our data with such excitement. And then really most of the time we go, that didn't work. And then you have to start over again. And that's how we learn. I mean, it has been enormously effective, but people don't report the millions of experiments that go anywhere. If you look at drug development, the vast majority of drugs never get beyond even just the safety phase. I mean, they do what they do to the mice and then, never go any further. And some of them might even work, but there's no enthusiasm, or there's already a medication in that category or something. But we don't talk out loud about our failures. So people in the general public think there are none, or they stop trusting us, because when they really need something, they find, we don't really have such a great drug for that right now. For what you need specifically, or your loved one, we don't have great options. So I think, it's a struggle. We in some ways overclaim, and then I think that makes people not trust us. It sort of, makes for an unfortunate cycle.
Yeah. I think we're kind of fixing this amyloid tau paradigm that I think a lot of people are trying to shift, but the mindset is kind of fixed in this. And coming to that, you talked about this divide between the Baptists and the so those who believe it's amyloid, those who believe it's tau. I'd never heard of those terminologies before. You did show that the amyloid hypothesis probably unlikely based on the studies that you've cleared amyloid, but the dementia still remains. Were you trying to say that tau might be a better target as a cause of or a contributory factor to dementia, or there is something else completely apart from those two?
Yeah, I mean, even in the few years since I did the research for the book, that has continued to evolve. And I'm not a basic science researcher, so I'm not at the heart of that and, the first to know about what's going on. So I do think tau is an excellent marker. When people get tau, timing that and tracking it seems to be a better predictor of who will have symptoms than just the amyloid plaques. We know that a lot of people with amyloid plaques don't have symptoms now, and a significant number never get symptoms. So not that helpful to us to know that you have amyloid. So I do think that tau is very important, but there also are 1,000 flowers blooming that are coming forward. Ideas that were looked at long ago and then sort of put to the side are now coming back to the fore. There's really interesting work on inflammation and on a number of other factors that may cut across a variety of types of dementia, looking at Lewy body or Parkinson's or frontotemporal dementia. So there are some really interesting mechanisms. Vascular disease, we've come to appreciate that actually the most common form of dementia is not Alzheimer's, but is mixed pathology. And that's with vascular disease, plus maybe you have some Lewy bodies, plus maybe you have something else. That's actually really interesting in terms of intervention, because if you only have drugs that attack amyloid, and you may have amyloid, but we don't know that it's what's causing their symptoms, then we've really not done enough to take care of different sorts of people. So there's that. There's also people who are trying to look at where does this amyloid come from? And there are some people who believe that it is the mark of a dead cell. So though it may not be bad to clear it away, you've already lost that cell. You're just taking the dead bodies off the field, and we ought to do that. But that's not a way to win the battle. That doesn't keep the body from dying. What you really like to do is intervene before that. It would be a much more sensible idea. So that may have to do with all kinds of different mechanisms. So it's actually quite, I think there is some real movement and some real excitement in the field, even while we have now some drugs that work on the principle of removing amyloid. And for some people, that's sort of like, well, that proves it, it's perfect, we don't need to look any further. I think that's not true. It's such an interesting article. It was published quite recently, I think in Nature, and I know that Risa Sperling is one of the multiple authors on it. They looked at people who have 2 copies of ApoE4, which of course, as a general rule, makes you very susceptible to getting Alzheimer's disease and earlier. And they looked at that, but they noticed that they proposed that this should be a subgroup of people that we carve out because they do have such an overwhelming likelihood of getting Alzheimer's disease. They also pointed out that this group is particularly at risk for the side effects of the monoclonal antibodies like lecanemab that we use. They have a very high rate of side effects like bleeding in the brain and swelling in the brain, which those drugs can cause. So even though that's focused on the amyloid cascade as a cause, they don't think the best drug for that group would be those that work on by this mechanism. So even for that group, this group of authors calls for different approaches to treating Alzheimer's disease. Let's sort of try, we need better and different kinds of drugs. We need to attack a different part of the pathophysiology, somewhere more upstream, somewhere, we need to try something new. So that gave me great hope that you don't have to get rid of the amyloid hypothesis and everyone who has spent their life working on it. But we can all agree that drugs we have today don't do enough for the people that we're trying to help. And so we need greater variety and we need innovation and we need to keep thinking about what are we not getting here? So I feel, I don't know if it'll be amyloid or tau or some thing that we tried before and didn't get far enough and now we need to go back to it, or some completely new thing. But I do think ultimately, I don't think it will help me, unfortunately, but I think ultimately people are beginning to think about this. And it's a good thing. This is how we've treated this is how we've succeeded with AIDS and cancer, everything. You have to have a multimodal way of attacking a bad illness. So in breast cancer, we have the medications, but sometimes we still also do radiation. We do surgery. We try and look at lifestyle factors that will protect you. Don't smoke. Look at your diet. All of that kind of stuff. All of these things can be helpful. And hopefully, if we look at this from all the different angles, we can come up with a recipe that will be better for our children and their children.
A good hope, but obviously cure from all the discussion is still a long way off. So I'm going to bring you back to care again. And when you are setting out your recommendations, the plan must be empathic, affordable, and flexible. And it must combine care with comfort, choice, and dignity. Is this an attainable ideal, or something that is it a mirage or an attainable ideal to be able to, to do all within care?
Yeah, it is an ideal, and by definition, we won't all get there. But I don't think it's a harmful ideal. I think there are some ideals that are a bad idea. We shouldn't be going in that direction. Thinness, the notion that everybody should be thin all the time. It's like, that's actually done a fair amount of harm in the world, even though, in the States, certainly many people are overweight or even obese. This notion that thinness is health, it's like, well, obviously we can carry that too far there, can't we? So that's a destructive ideal. I think this is a good ideal. This is good to think about. You may not be able to get a perfect setup, but you could influence the way you would live in old age with dementia if you're lucky and you're thoughtful. We don't all have infinite resources, and that's fine, but it isn't only about money. It's also about what are the things you really value, and what are the things that people tend to keep with them. So for that reason, it's important to think about what brings us happiness as a general matter. And that tends to be it's not really money. I mean, you have to have enough that you're not terrified of not getting food, but beyond a sort of, basic kind of decent, okay, I have a roof overhead and food to eat, which, many people don't have either or both of those things. So once you've got that, they don't really look like money is kind of everything. Probably relationships, having, with family, if that's worked. Not everybody has that, but having a community where you're sustained. I think it's really important to think about multi-generational communities. It used to be the norm that there would be multiple generations of a family living together. And then for some reason in the 20th century, we decided that was bad, that, children should move out. Nobody should have old people with them. Old people should live in little old people ghettos, and that would be the way to do it. Actually, I think that's really coming into question now in interesting ways. There are plenty of people who really embrace being grandparents. They don't want to live in a special community where you have to be 50 or older.
Yeah.
And some people have lost their adult children, so they will be the primary adult for their grandchild. So you're not staying in that, over 50 community in Florida if you're raising your grandkids because of cancer, because of AIDS, because of the, opioid epidemic or whatever. But I think other people have embraced it because it feels good and healthy to live in a multi-generational format. So, thinking about what would work for me, what would I like, what would bring joy, what would bring a sense of that I could continue to learn, I could continue to contribute, that there would be a reason to get up. So all of that, which is just to do with happiness as we age, I think is part of embracing, and with aging, I'll decline in some ways. I may also lose some of my cognitive functions. I certainly won't be able to run as fast and do other things. I may have trouble doing, arithmetic in my head as well. And not to trivialize dementia, it is a very serious illness, but for a long time, it's an illness you could live with. And focusing on that and how to do that better is where I think we could all do a bit more and make it less scary, and also think about what things you can do to make it not as likely for you. It seems to make a difference. The only shadow of good news in dementia is that the absolute numbers of it are increasing because our population's aging. But if you look at each cohort, the 70-year-olds, the 80-year-olds, the 90-year-olds, the percentage of people with dementia in each cohort is shrinking. So we're doing something right. We're doing better care for controlling high blood pressure, controlling better care for strokes, for heart attacks, stopping smoking, which is good for your lungs and frankly for your brain as well. So there are some things that are getting better, and I'd like to see us do more of that.
Cognitive reserve as well.
Yeah, cognitive reserve as well. You and I are in good shape in some ways because we were privileged to get an education. We're very cognitively attuned. We use our noggins, and that's good for you. But it doesn't have to be limited just to people with super high education. My husband is also educated, but loves to do carpentry. And I was observing a few years back where he was building a staircase. That is mathematically so challenging. You've got to take the thing on an angle and figure out how, coming out from this, you're going to have the steps at, right angles to the ground. And then, it's just like, I couldn't even get my mind around it. So I think there are things that we can do, and it will be different for different people, that actually are an important way of using your mind. And it's, like a muscle. It's much better to use it than not.
One of the most uplifting statements in your book was, dementia lasts roughly 10 years between diagnosis and the end. That's too much time to just wait for death. I'm guessing that's one of the key messages of your book. Are there any others we've missed out? Any kind of thing you want a reader to take away from the book?
I think that's absolutely key, that you should always be focusing on living. And, death will come and find you. You don't have to hide from it. But really focusing on the examined life, how you would like to live. And we can't perfect our lives, but we can be accountable for the choices that we make and the things that we do that actually support the people that we care about, support ourselves, and kind of enhance humanity and joy and dignity, all those good things. And typically, if you do that right for yourself, you probably will be doing it for the people around you as well. So if you're a happy, grandpa or granny, that's actually very helpful to your family members in the next generation, that they don't have to, you're not miserable and you figured out sort of some things that would make you happy. That will make them happy too. So I think that's actually really important. And also just, we're a very, of course, youth-oriented culture, and youth is a time of great beauty and dynamism. But all parts of the lifespan are quite valuable and interesting. It's okay to age. It's okay to be older. It's okay to have gray hair. All those things. It's a normal part of living, and we don't need to be so fussed about not being young and youthful anymore. It's like, if you succeed, you will get old. It's a sign of success. It's like, you're not going to be 18 for very long at all. So get over it.
Good message, I have to say. You talked about the film you are doing. Is it? Tell me a bit about it. I couldn't let you go without asking that.
Okay. So, who knows if this will ever see the light of day, but I'm having so much fun. I was able to step down from my main job. I was the director of a center for bioethics. I stepped down, and I'm still doing some teaching, which I love to do for them, but I basically handed off all the heavy lifting, and I'm now doing all sorts of projects, and I don't really work full-time for my institution anymore. I'm just doing projects, and among them is I found two people who actually do know something about film, and we are working on a project that's in a state of evolution. And again, it's very easy to talk about making a film. It's extremely difficult in my limited experience to actually get one made. But I think what we'd like to do is, what it now is a kind of limited television series where we will look at a handful of people who have been given a diagnosis of 6 months or less to live. And this will be fiction, and we will follow them about and see how they are living. And the point would be that it's not about medical decisions, not in the hospital. It's not just about, chemotherapy and this and that, although it certainly will be a reality for some people like that. But it's also about the fact that mortality is inevitable, but there are infinite choices in how you may respond to it. So we'd like to look at people at different ages and different places with different reasons to be concerned about their health, and see what they do with that, and see where that goes. And it should be joyful. It should be funny. It should be beautiful to look at. So some will be out in beautiful places in the country or doing different things. There should be music. It should be full of life, because the point is that you are full of life until you're not. And you shouldn't gradually let the air out of the balloon. There's no reason to do it that way. Go out with a bang to extend the metaphor beyond all reason.
Okay, I can see the link between that and your book. The message is still life is
through line. Yeah.
Okay. Any books you would like to recommend, either on dementia or brain?
And your questions. Yeah, I think I would recommend, I have 3 in front of me, and they're really just about aging healthily, because I think that's the best way to deal with dementia. So I like this book by Vivek Murthy, who was is the Surgeon General in the United States. He was in the Obama administration and again now. And he's written this book about loneliness, and actually drawing a lot from UK medicine. He went to the UK, and there's a lot in this book about sort of the focus on loneliness and addressing that at all ages, but particularly for older people. So I think actually embracing that and figuring out how to build and sustain communities is a really important part about being happy, and particularly as we're older. Here's a book that I like, but I don't really like the title. It's How to Live Forever by Mark. He actually doesn't necessarily want you to live longer. He wants you feel as if you've lived forever because you've made connections with young people. He is a kind of Jedi master of the group of people, kind of a movement, if you will, that looks to collaborations across generations. So he's looked at co-housing among older people and younger people. There are lots of places in the world where the older people have too much housing. They bought a house, but it was cheap. They raised their family there. Now it's just them and their 5 bedrooms, and they don't need that. But they're right next to a university where the students don't have a place to live and they don't have much money, so they don't mind it. So you can sort of bring people together in a way that is incredibly sustaining for both groups. Everybody wins. The young people can hear from an older person about what they've learned in their time, and the older person can have someone. I mean, one of these things started in Boston where it snows like crazy all the time. They can have a young person help shovel the snow off the walk so they can come and go and help carry the groceries. So he's really into collaborations among generations, which I think is actually an incredibly hopeful and useful thing to focus on for everybody. And then this book by Robert Waldinger and Mark Schultz, The Good Life, is drawn from the Harvard study of adults or adult aging or something like that. There was a prior book by every 20 or 30 years ago, they pulled together all of their data. It studied young Harvard students who were at that point all male, starting in, I think, the 1930s or so, and periodically results on how they're doing as they get older. And the data is actually beautiful. What makes you happy in old age is relationships. So, building relationships with family or even with the friends that you were on the crew team with in university, decades ago. So that and meaning, being able to give back to other people and continuing to learn. Those seem to be the things, but the relationships clearly at the top of it. And, if it's a spouse, that's fantastic. If you get to the end of your days and you've been married to one person happily for 71 years, you're fortunate and rare. For other people, it is certainly possible to look at the people around them and be part of a lively and vibrant community. So I would recommend those, which really focus more on the general problem of how can you be both aging along and either being equally or even more happy as you get older.
So still within the network of society and not bumped off out of the system.
A vital part of the world until you're no longer there.
Excellent. Tia Powell, thank you very much for your time and your insights. I'm very grateful. To my audience, if you enjoyed this, you might want to check my book, Surfing the Brain, not as inspiring as Dementia Reimagined, but kind of tidbits of neurology. And for a bit more of the academic stuff, I have a website called Neuro Checklist. You might want to check that. And to make sure you don't miss the next episode, why not subscribe to the iTunes, Spotify, or YouTube channels of the podcast. But until then, thank you very much for joining me. And Tia Powell, thank you very much for your time. I'm most grateful for that.
Thanks for your conversation.